within the time limit. Thank you again, for having me. So this is the title, as you said. Let me advance my. Okay, so I'd like to start from a very brief introduction of the place where I work. So I work in the FM Kirby Research Center for Functional Brain Imaging. So we're a national imaging center at Johns Hopkins and the Kennedy Krieger Institute. So we have, we mainly do magnetic resonance imaging. So we have a research dedicated MRI scanners. For example, we have the most commonly used 3 Tesla scanners. And we also have a so-called high field 7 Tesla scanner for research in human studies. And because we do lots of children's study, pediatric study, so we have so-called a mock scanner where there's no actual magnet, but we before the kids go into a real scanner, they can get used to the environment of MRI scanner. We also have a preclinical small animal scanning facility as well. So for myself, by training, I'm a biomedical engineering background. So my main research interest is to develop novel MRI methods, especially to imaging the function and the physiology, neurophysiology in the brain. For example, I'm interested in very high spatial resolution functional MRI to look at different layers of the cortex. I'm interested in imaging methods for small blood vessels, and more recently, the so-called lymphatic vessels. I developed methods to look at the metabolic changes in the brain, and I'm particularly interested in ultra-high field 7 Tesla MRI technique. The reason is I think those are the future of the field. So, so over the years, I've been very fortunate to have a chance to collaborate with various clinicians, especially Johns Hopkins and other places, to apply these methods to various diseases. So today in this talk, I'll focus on our application in tumor imaging, especially looking at the small blood vessels. So, so I'm gonna first talk about a little detail about some detail about the methods we develop. So I hope that could be informative, and then I'll show some results in tumor imaging. So so we in this method in this method and the study, we're interested in so-called cerebral blood volume (CBV). So this is probably one of the most commonly measured parameter with almost all the neuroimaging techniques. So, but the main issue here is when we talk about in most methods, so we have so far today, when we talk about measuring CBV, what we measure is the so-called total CBV, which includes all different type of blood vessels, arterial, capillary, and venous vessels. But of course, these vessels are very different in terms of physiology and pathophysiology. So we had a recent review paper talk about the difference between arterial and venous blood vessels. Just to give you one quick example. So this is actually from from an animal study using 2-photon optical imaging. So what they can actually see an arterial and vein, small vein in the cortex, and then in this animal during a 4-port stimulation. So as you can see, during the 4-port stimulation, the diameter of the arterial changed quite large, quite significantly, but the venous vessel does not change that much. So this is just to show you how different these vessels can be in response to functional changes as well as pathological changes. So, and there's lots of studies showing that the largest relative change, the most sensitive change, comes from the arterial vessels, because these are the vessels that can actively dilate and constrict. So we want to develop methods that can measure arterial vessels separately from the rest of the microvasculature. So we set off with the method called the vascular-space-occupancy MRI. So very quickly, so the basic principle of this method is actually very, very simple. The idea is we use a so-called inversion pause in MRI to reverse the signal from tissue and the blood. And then after that, we wait for a period of time for them to come back. And because the rate of this recovery is different between blood and tissue, so when the blood signal goes to zero, comes to zero, the tissue signal is slightly positive. And if we take an image at this time point, we'll get a so-called blood volume weighted image. From that, we can calculate the blood volume. But the original VASO method, we still measure the so-called total blood volume that includes everything, right? So how do we measure arterial blood volume only? So what we did was we can selectively, instead of inverting all the blood in the brain, we can selectively only invert the blood in the feeding arteries and then wait for them to come into the brain's at the imaging slice and take image. And by doing that, we are affecting, or we are inverting dominantly arterial blood, and therefore we measure arterial blood volume. Of course, it's not that simple, because it takes time for blood to go from, for example, the neck region into the brain. And the key point here is we need to make sure that the time for the blood to traverse the gap between the neck and the imaging slice is similar to the so-called inversion recovery time we typically use in these methods, which is determined by the T1 relaxation time, so-called in MRI of blood. So unfortunately, these two time do match very well according to literature. So we can achieve predominantly arterial blood volume. So we call this method IVASO. And then in order to calculate the blood volume, of course, we need a so-called control scan where the blood signal is not affected. And then the difference between these two scans, we get a different, we get a difference signal that's proportional to the volume of arterial blood vessels. And then we can do use so-called crusher gradients, that's an MR technique, to remove signal in large vessels so that we can look at more smaller vessels that's more closely related to local perfusion of brain area. So, and then so this shows that if we use different so-called inversion time, that's a time of wait until the blood coming to the slice. We can see that as the TI, the inversion time gets longer, as more blood gets into the slice. And then by doing that, the good thing is that we can actually fit this signal, this time course, to a biophysical model of this IVASO signal. And from there, we can get the absolute arterial blood volume map from this fitting, as well as the so-called arterial transit time. The main reason that this is important is because in different brain regions, as you can see, the arterial transit time can be very different. So we cannot just take one image at one single time point. We have to take image at a multiple time point and fit to this curve so that we can get the arterial blood volume and arterial transit time in different brain regions. And then, of course, people always ask us, how are you sure that you're measuring arterial blood volume? So this is actually a great question, and frankly, this is very hard to validate. But we did a few experiments to validate that. So first is we can measure the so-called T2 or T2 star relaxation time. As you can see, these time constants are very sensitive to the oxygenation level of blood in blood. So in arterial, it's a lot longer than capillary or venous. It's also very different from tissue and the CSF. So we measure that. We measure both T2 star and the T2 of the different signal in the IVASO method. So as you can see, when the inversion time is closer to arterial trend time, the T2 and T2 star value is closer to arterial, is in the arterial range. And then, when the TI, the inversion time gets longer, that means more blood comes in, possibly some capillary blood, and the T2 and T2 star becomes much shorter towards the capillary range. So this gives us some confidence that we are indeed measuring arterial blood volume when the arterial trend time, the TI is in the arterial trend time range. Okay, so this method originally, when we developed that, it was on 3 Tesla. And then, as I mentioned, of course, I'm very interested in 7 Tesla technique, so we implement that on 7 Tesla as well. As you can see on 3 Tesla with 3 millimeter isotropic resolution, it's pretty okay. But when we go to higher spatial resolution, 1.5 millimeter, it's actually 1/8 of the VASO in 3 millimeter because it's cubed. So the 3T images start to show some noise, show lots of noise. But on 7T, actually, we can get a reasonable map as well. And the parameters are same. So this shows you, I hope you can appreciate the signal enhancement on higher magnetic field. Okay. So, so this is the technology. We have, since we developed the technology, we actually have applied it to in lots of different brain diseases. For example, we have looked at the Huntington's disease, some neurodegenerative diseases, for example, Huntington's disease, Alzheimer's, Parkinson, and we also look at the change in some psychiatric diseases, disorders such as schizophrenia. So what I'm going to show here is an example. We applied this method to brain tumor patients. So this is from one study we did. So the goal here is, of course, we want to use our IVASO method to measure arterial blood volume in these tumor patients, and we want to compare it to the, I think currently the gold standard perfusion or CBV method that's called a DSC, dynamic susceptibility contrast MRI CBV measure in the same patients. So for IVASO MRI, we do not need to do any injection of any exogenous contrast agent. But for DSC MRI, as we know, we use the so-called gadolinium-based MRI contrast, and usually we need to do IV injection in these subjects. These are clinically very standard protocol, but more recently there have been some reports that these contrasts that may be may have potential problem, especially in subjects who has liver and kidney problems. So if the IVASO method can produce similar results as DSC MRI, then I think it can provide a useful alternative for these patients, especially if the patient has kidney or liver problem. So this is from one patient in a study. So first we did some structural imaging, MP-RAGE, and a FLAIR. So from there we can see the tumor region pretty well, especially the FLAIR region, and we select a control region that's a contralateral control region. And then we look at the DSC method. So from DSC, you get a total blood volume map. It's not arterial, it's total blood volume. You also get a so-called mean transit time map. And for IVASO, you get arterial blood volume map, and then you also get arterial transit time map. So, okay. So from there, we imaged, I think, we imaged these tumor patients, and we calculate the blood volume, mean transit time from DSC, and arterial blood volume and arterial transit time from IVASO. So what we found was, first of all, with IVASO MRI, the CBVa value seems to correlate with the grade of the tumor pretty well. It showed a good correlation. On the other hand, in the DSC method, the total CBV seemed to show a good correlation as well, but not as good as the arterial blood volume. So the p-value and also the R-square values are worse than the IVASO methods. And then the second, we look at the mean transit time from DSC and arterial transit time from IVASO with their correlation with tumor grade. And we didn't find a significant correlation from either of these transit time measures. And then we want to look at the correlation between these two different measures. Okay. So for IVASO, that's arterial blood volume, and DSC CBV, the total CBV, we seem to find a reasonable correlation. But because of DSC, note again, we are measuring total blood volume. IVASO, we're measuring arterial blood volume. So these are basically two different measures. So it's they do not agree with each other completely. And for mean transit time and arterial transit time, again, of course, they are very different. Arterial transit time is the time for the blood to traverse the arterial vessels. The mean transit time is the time for the blood to traverse the entire microvasculature. So we did not find a correlation between these two measures. And then in the second study, we took these methods, and we did this in a slightly larger cohort, 45 patients, and 14 of them have grade 4 glioblastoma, and 14 that's a grade 4, 14 is grade 3, and 17 is grade 2. So we did IVASO measure in the tumor region, again with IVASO. And using these IVASO methods, we calculate the ROC curve in terms of distinguishing between high grade and low grade tumors. So the ROC curve from these results, the area under curve seems to give quite good results for this kind of differentiation between different grades. And then in a third study, we use the same method. We imaged 20 patients with glioblastoma and 22 patients with solitary brain metastasis. So again, we used in these patients, we used the IVASO measure as well as the DSC measure. So as you can see, the IVASO measure seems to be superior in terms of differentiating between GBM and SBM, where the DSC method, the area under curve is much smaller. So this is in collaboration with Dr. Wu in Nanfang Hospital. So in summary, what I talk about is a method we developed, a so-called IVASO method, to measure arterial blood volume separately from the rest of the microvasculature in brain. So the main advantage to us is, one, it can measure arterial blood volume. Two, it is a truly non-invasive method that does not require any injection of any exogenous contrast agent. So compared to the commonly used dynamic accessibility DSC MRI, that could be an advantage and it could be a useful alternative for certain patient population. And in our study, it seems to show that when IVASO, the IVASO measure, the arterial CBV measure seems to be more specific than the total CBV measure from DSC in terms of stratification of brain tumor at different grades. So given those, we thought IVASO may be a useful alternative, for measuring tumor perfusion, especially for patients who has problems sometimes with the commonly used gadolinium contrast agent, and then that becomes difficult to use DSC, and then IVASO can be a useful alternative. Of course, we will continue to do this work and to expand the cohort so that we have a stronger validation of the method and the clinical results. So with this, I would like to thank my colleagues from our center. And also, I'd like to thank my collaborators, from the neuroradiology division and the neurosurgery division and the neurology division, from a Mayo Clinic and the Nanfa Hospital. And of course, I think funding support is very important for us to do this work. And some of and also I want to thank my group in particular, because they are the people who actually did the work. So with this, thank you again for having me, and I will be happy to answer questions.
Thank you so much, Dr. Jun, for being present among us and sharing your informative research work. Thanks a lot. Yeah. Dr. Jun, we were having a question for you right from the beginning. Somebody just emailed me and asked me, please ask Dr. Jun that what motivated him to become, to go for the Department of Radiology.
Yeah, so it's so the radiology department is probably the best department here for this kind of work. So it's the largest department in the School of Medicine, in Johns Hopkins School of Medicine, that's related to imaging. And I myself is a biomedical engineering major, so I develop methods. But the radiology department also provides a platform that we can collaborate with clinicians from various departments. So this is really, I think, the best position for the work I want to do. So
that's great.
That's why.
That's great. So is there any kind of story behind it that you chose this field?
Not really. That's so my undergraduate training is in electrical engineering and computer science. So I started to do some work in image processing, and then I realized that if we can improve the image to start with, if we can get more better quality image, then it will make image processing a lot better. So I start to do. So that's why for my graduate work, I start to do MRI. So yeah, and then I really enjoy what I do now, and I hope it's going to be useful to some studies at least.
It will be, I'm sure it's going to be.